I'm delighted to invite back Dr. Salman Razvi. He's been here with us today and also yesterday. He's a senior lecturer and honorary consultant endocrinologist at Newcastle University, who's going to give a symposium entitled The Art of Precision, Achieving a Consistent Euthyroid State.
It's a great pleasure to be here with you today to talk about achieving a consistent euthyroid state and how we can master the art of precision. Three questions we'll ask ourselves today is, why should we achieve a euthyroid state? And is it really important? And finally, how do we achieve that, and that too in a consistent manner? So first, going on to the why part of it. There is this kind of obsession to have everything in normal, and that includes blood results. So it's not just within patients. Patients look at their blood results and they want to see all the parameters to be within the so-called normal range. And that doesn't just limit itself to patients. A lot of clinicians also have this measure of trying to get everything to within normal. So I think it's one of these things that we have to be mindful of. But as we all know, the art of medicine isn't just about normalizing numbers or assessing numbers. If it was just treating numbers, we would be out of a job and you'd have computers that would do it for you. But we look at patients, we look at their symptoms, we look at their family history, we examine them, we look at the totality of the situation and examine everything in a holistic manner. And the blood results are a complement rather than the main part of our clinical consultation. So the ATA guidelines about the clinical and biochemical goals of levothyroxine replacement for primary hypothyroidism say that thyroxine treatment has three main goals. Firstly, to provide resolution of the patient's symptoms and the hypothyroid signs. Two, to normalize serum TSH with improvement in thyroid hormone concentrations. And three, to avoid overtreatment. And this recommendation is strong, based on moderate quality evidence. So it just doesn't talk about normalizing TSH. And I think this is also important that we focus on all these three things. And what's really important to remember is that there's no universal formula that will suffice for everyone. I think every person is an individual, and we have to keep that in mind. So if everyone had to have the same TSH, it would be really difficult. Now, one of the downsides to this is that we have a number of a high proportion of patients who are on levothyroxine treatment who still feel tired. And this is what I did. I went onto Google and entered tired on thyroxine, and I came up with all the different websites, including books, including self-help groups. And some of these are quite scary if you look at the headlines. Is your thyroid making you ill? Now imagine if you're a patient and if you wanted to really go and have a deeper delve into the issue, you could end up thinking that all your problems are related to the thyroid. And it might potentially point you in directions that you don't really want to be venturing down on. One of the issues, I suppose, is that the symptoms of hypothyroidism are really non-specific. Dry skin, poor memory, slow thinking, weaker muscles, more tired, and on and on and on. I feel like that on a number of days, especially when I've had a really long day. Does that mean I've got an underactive thyroid? I don't think so. But if you do have an underactive thyroid and you do have a number of these symptoms, you could end up thinking it is down to my underactive thyroid, and if you're on treatment, that the treatment isn't really working very well. So the problem is that because these are non-specific symptoms, it's very difficult to narrow it down to one issue or the other. And it could be down to a number of different reasons rather than just being the thyroid. And what I thought was really interesting is this very, very recent article that's been published by very esteemed colleagues, including my colleague here in Newcastle, Petros Peros, and they sent out a questionnaire to thousands of patients, and they looked at a patient health questionnaire which has 15 points on it, and they could look at somatic symptom disorder based on that questionnaire. And what they concluded is there's a high prevalence of probable somatic symptom disorder among people with hypothyroidism, and there were associations between this disorder and negative patient outcomes, including a tendency to attribute persistent symptoms to hypothyroidism or its treatment. So it's by no means definite cause and effect, but it does suggest that somatic symptom disorder, where internal organic issues might manifest as a somatic symptom. For example, fatigue might be a manifestation of stress, might be a manifestation of worldly other issues going on with life, is probably a strong determinant. And I think this is really important to consider, rather than focusing itself on a number of TSH or a free T4 or importantly T3 in this case. Moving on to, is it really important? I think yes, the issue itself is, and there are multiple other papers that would support this finding, but for obvious reasons, I have chosen to highlight this paper from 3-4 years ago, which looked at the prevalence of levothyroxine-treated hypothyroidism over 10 years in the UK, and it showed that year on year, there's been an increase in the number of people getting treated with levothyroxine. And when you adjust it for, people getting older and, women, percentage, smokers, so change in demographics and obesity and all that, even once you adjust it for all that, there was a significant increase in the number of people being treated year after year. And back in 2014, there were about 2.3 million individuals who were on treatment with levothyroxine. And my understanding is that currently that figure approaches around 3 million. So in a country that's, which has 67 million individuals, 3 million is a relatively large proportion. It also comes at a cost. So what you see on the right hand is a graph that shows the total number of hypothyroid patients who have been prescribed levothyroxine so in 2019 and 20, the number of people that were prescribed levothyroxine was close to a few million. And delving deeper into it, approximately about 20% of hypothyroid patients feel tired or have other symptoms of hypothyroidism. And in England alone, within the UK, the annual spend on hypothyroidism actually peaked in the year 2016 and 17 at 122 million pounds. That's about 150 million US dollars per year. And of that, around a quarter was spent on T3. Now, thankfully, that number has come down as there's been a fight back by the drug regulators to some, unscrupulous drug manufacturers that were increasing the costs of both T4 and T3. And related to that, we see this reduction in the costs of T4 and T3 to the UK drug market. But keep in mind, this isn't just drug market. These are the population, because the NHS is publicly funded. So it's being paid for by tax money. So I think it's really important that we focus on this issue. Now, the problem is there are no simple solutions to these complex issues. For example, if somebody's feeling tired, people want to look at a simple solution. Look at energy boosters, look at supplements, have coffee with sugar, use social media to look for solutions. Whereas the solution might be drinking more water, putting away technology, more exercise, getting more sleep, or even maybe a combination of these factors. So those are difficult things to do, but people want easy solutions for life's complicated problems. I think we need to filter out the noise and, sometimes finding or trying to find simple answers to complex problems will lead to a bad decision with not very good outcomes. I think that's important to remind ourselves. Now, what we also know that even within the levothyroxine group, not everyone will have a TSH that's within the reference range. And by no means is this a definitive review of the entire literature. But in 5 studies that are now fairly old, but the recent literature hasn't really changed a lot, we find that a high TSH is present in approximately 15–20% of levothyroxine patients, and a low TSH is also seen in 15–20% of patients. So approximately 40–50% of patients on thyroxine will either have low or high TSH whilst on treatment. So, and this is important. And there are a couple of studies. On your left-hand side of the screen is a study from Scotland, where Graham Lees and company looked at TSH over time, which was either suppressed, low, normal, or high, and looked at cardiovascular events, dysrhythmia, which was mainly atrial fibrillation, or fractures, and found that both low, suppressed, and high TSH was associated with all these clinically important events, whereas a normal TSH wasn't. And more recently, the study from hundreds of thousands of individuals on the NHS database. And again, you find that a lot of these outcomes, including mortality, is higher when the TSH is low or suppressed or even high. So again, suggesting, again, by no means this proves causal associations, but it just shows that both low and high TSHs are associated with worse outcomes. Now, there could be any number of reasons for this association, including unmeasured or unknown confounders, possibly lifestyle, possibly things that may account for people not taking the thyroxine more regularly, and so on. But again, there's this suggestion that the relationship may need to be more tightened. Now, what are the usual causes of an inappropriate levothyroxine dose in an individual? Now, the most common thing that we find is compliance. So, and it's not unique to levothyroxine. We find this in most of the chronic conditions like hypertension, like heart failure, type 2 diabetes, is that taking the same medication in the same manner every day, day in and day out, isn't easy. So a number of people may forget to take their medication, may not take it an hour before food, may not take it separately to the other medications, and so on. So I think that's still the predominant factor. But other factors like, not storing the thyroxine properly, switching between the various products, absorption being not exactly the same every day, the effect of food and other drugs, the time of administration on a daily basis, there's a need for alteration in specific population, for example, as one gets older, during pregnancy, during illness, and so on, and certain gastrointestinal disorders, including things such as, people who have had bariatric procedures, including surgery. There might be issues related to that. Now, again, a very recent study, which has, just been published from Belgium, which looked at a community population. And what it did is looked at 856 adults that have been using thyroxine for more than 2 years for hypothyroidism. And what they found is a quarter had abnormal TSH levels, and 28% of patients admitted that they were not adherent to treatment, and that meant not taking the thyroxine consistently more than 80% of the time, which equated to about 73 days per year not taking the thyroxine at all. And 39%, almost 40%, complied with taking the thyroxine more than 30 minutes before food, which meant the majority, that's just more than 60%, actually took the thyroxine within 30 minutes of food. And again, you can see all these variables. So if you took it, more than 30 minutes for certain days and less than 30 minutes between food and the medications, certain other days, you will have problems in the TSH levels being high and low. So that's the very likely, or most likely explanation. The conclusion was that many participants with hypothyroidism do not use the thyroxine as effectively as possible, particularly with respect to timing of administration in relation to food. But most people actually feel well, and there's no significant correlation between correctly using levothyroxine and their thyroid health. So that's really important to know. There are other factors that affect the stability of thyroxine, including what the excipients are, and we'll talk about this a little bit more in detail further down the line. The packaging of the thyroxine, airtight, light-resistant containers are much better in keeping the stability of the thyroxine more than blister packs. Ideal temperature, 15 to 20 degrees is best. If you keep it in outside, when the temperature is 30 or 40, it'll degrade much quicker, and so on. The humidity, so if you keep it in the kitchen or in the bathroom, where humidity is likely to be higher, it will degrade much quicker. Oxidation and light both have effects, so therefore having airtight containers which are light resistant is much better. Does changing the dose and trying to get the TSH within a certain parameter make a difference? So there have been a few studies, but probably the most robust of these, and I'll just very briefly mention two of these. The first one was by John Walsh in Western Australia, and they had 56 people with levothyroxine-treated hypothyroidism enrolled in their trial, and they had 51 people who completed both treatments. And they concluded that small changes in levothyroxine dose do not produce any measurable changes in hypothyroid symptoms, well-being, or quality of life, despite the expected changes in serum TSH and markers of thyroid hormone action. So what they did is that they had 3 groups where they randomly allocated the usual thyroxine, slightly lower thyroxine, and slightly higher thyroxine dose to try and aim for TSH levels in the middle of the range, higher end of the range, and lower end of the range, and found that making these very small changes to dose didn't really make a difference in a blinded fashion to how people actually felt when they didn't know what dose they were on. The other and really important story that fits into this is by Mary Samuels, and this is a really interesting trial where they had 138 patients with levothyroxine who were randomly allocated to an unchanged, lower or higher dose of levothyroxine in a double-blind manner, and that's important. That both the patients and the researchers didn't know which area they were allocated to. The thyroxine was changed every 6 weeks, and certain parameters such as quality of life, mood, and cognition was assessed after 6 months. And what they concluded is that altering the levothyroxine dose in hypothyroid patients to vary TSH levels in and near the reference range does not affect the quality of life, mood, or cognition. What was interesting, however, is that the patients who preferred a perceived higher thyroxine dose felt that if they were on a lower dose, they were unwell, and vice versa. So it all comes down to what the perception is. If somebody perceives that higher thyroxine means better quality of life, and if they perceive that they're not getting the right dose or lower dose, they will perceive their quality of life to be worse off. So what I think they concluded is that adjusting the thyroxine dose in hypothyroid patients based on symptoms may not result in significant clinical improvement. And I think this is really important to remember. And finally, coming to how to achieve a euthyroid state. And I think it's important, not for generally everyone, but particularly in these groups, for example, in children, for obvious reasons, in the elderly, where you really want to avoid overtreatment, in patients with thyroid cancer. Again, this is a moving field where this old dogma that we need to suppress TSH for every thyroid cancer patient is being challenged, and there's a lot of literature, and thankfully guidelines are changing around this. In pregnancy, again, it's an important area, but again, current guidelines suggest that people on thyroxine should have the TSH within the range, and ideally TSH levels towards the lower end if possible. And again, there are lots of patients where there's a history of difficulty to reach TSH level within the reference range, and therefore trying to achieve a TSH level within a desired range in this group in particular, groups in particular, is important. I think it's important to remember that achieving a euthyroid state is individualistic for everyone, and the target TSH has to account for a number of factors, including the age, the cause of the hypothyroidism, what other medical conditions they have, their other drug history, timing in relation to food, pregnancy or not, whether they have thyroid cancer, and all these kind of things. And one of the kind of balancing acts is trying to balance the TSH levels with the perceived symptoms. I think it's important that we use a high quality product. Switching between various brands or brands to generic has been shown to impact on TSH, and there can sometimes be variation in the dose, even at the same stated dose on the tablet of more than 10%, and there's a lot of literature around this. And the other thing to remember and highlight to patients is combination therapy of T4 and T3 is difficult to monitor, but if you do go down this route, try and avoid having a suppressed TSH in these patients. And I find this, and a lot of other clinicians find the levothyroxine absorption test very useful in people where the TSH doesn't normalize despite being on high doses. And I won't go through this in detail, but I've got the reference of this paper from the Lancet in 2017 highlighted. So if you're interested, please go in and have a look, and indeed try and use this in your everyday practice. I certainly do it, and I find the absorption test a really useful test. So very briefly about the new formulation, I understand that the Merck new formulation is widely available within the Middle East, and it's the predominant levothyroxine brand that's available. But very briefly mentioning, why was there a need for a new formulation? It was predominantly down to certain healthcare regulators, including the FDA in the US and France's healthcare regulatory authorities, and the UK MHRA wanting a much tighter formulation. So that's the reason why the new formulation was brought to market. And what it means is there's a tighter content specification over the shelf life of the product. So in both France and the US, it was brought down from 90 to 110% of the stated dose to 95 to 105%. So for example, if it's a 100 microgram tablet, it could contain anything between 95 to 105 micrograms over the shelf life of the product. And in the UK, it's slightly different from 90 to 105 currently, which is different to what it used to be previously, where the range was much wider. And the reason for that is fluctuation in the daily dose of 10 to 20% may lead to clinically significant changes in TSH. And because as thyroxine is classed as a narrow therapeutic index drug, that was the reason. Now, the objectives of developing a new formulation were twofold: to improve the pharmaceutical stability and to also ensure potency specification of a shelf life of at least 18 months. But what's important is that the new formulation that you have available now actually has a shelf life of 36 months, which is very different to the 2 years that you had previously. And what's also important to remember is that the 95 to 105% of the dose will be within that for the entire shelf life of the product. And there have been a number of tests that have been done to confirm this. And again, data has shown that the new formulation lasts within those levels for a much better time period than the old formulation and possibly some other formulations that are available in your region. So what's different in the new formulation? The active ingredient remains the same, it's still levothyroxine. The shelf life has changed from the previous 2 years to 3 years, as long as it's protected from light and stored in the original packaging. What's changed is that lactose has been replaced with mannitol, so it could be helpful in people with lactose intolerance. It has maize starch, it has cross-cellulose sodium, gelatin, mannitol, magnesium, and citric acid. The citric acid is there to add taste and also to help with absorption, as we know that acidic environment helps a better absorption of levothyroxine from the upper GI tract. And data that has been, again, published before shows that compared to the previous formulation, the new formulation in healthy volunteers leads to total T4 levels that are pretty similar across various doses. So in summary, the new formulation of levothyroxine is bioequivalent, has tightened specification, and the dose is administered within the range of the old formulation, so the dose shouldn't change. No TSH test is required upon switching to the new formulation, and it should be pretty straightforward. And the reason why I mentioned this in, talk about, dosing in particular and, achieving a euthyroid status, because it reduces the variation within the dose from the previous 90 to 110 to a much tighter specification as longer, a better stability over the shelf life. This should lead to a much better TSH response in patients, although that is yet to be tested. But in theory, that would be what it is. So to summarize, achieving a euthyroid state is important, potentially to reduce adverse events. An individualized approach is important. Non-adherence is common, and we need to work on that. Small changes in levothyroxine dose probably have very little or no effect on symptoms, but the long-term effects are really unknown. And standard high-quality thyroxine preparations are available and should be used, and switching between products should generally be avoided, particularly if you have got one of those high-risk groups that we talked about. So thank you very, very much for your attention, and have a good day.
We'll move now to the abstract award session. Out of 4 oral presentations, we selected the 2 winners, and I'd like to thank the researcher for submitting their abstracts, and also I'd like to thank the Abstract Evaluation Committee. We'll start with the second award, and this goes for Bharata Rani for the abstract titled Clinical Association of Thyroid Eye Disease with Disease Severity and Thyroid Functional Status. Congratulations, Bahrata. Now for the first place, it goes to Mu'taz Usman for the abstract titled Correlation between Thyroid Nodule Initial Cytology, Ultrasound Features, and Final Histopathology Findings. Congratulations to our winners, and they are really well deserved. So then the winners will receive the certificate for winning the abstracts, and also